Well, thank you so much for that kind introduction. Hello, everyone. Dr. Rogers, thank you for having me. And it's nice to see you all. And it's Doctor's Day, is that what you said? There we go. Okay. So they're feeding you today? Is that the unique thing about Doctor's Day? Anyway, it's fun to be in Texas and in Houston, and here's what I'm going to do. So in terms of conflicts, this trial and most of my work has been funded by the NIH, which, we usually say is not a conflict, but of course it is. I mean, we all have our own biases, and you'll see, I'll share with you my perspectives here. So what I'm planning to do today is begin with an overview of transfusion in general. So we'll talk a bit about the risks of transfusion and the risks of anemia. I'm going to emphasize the clinical trial evidence because that's really what you should be basing your decision-making on, show you guideline data, and then finally summarize for you. Now, I always like to begin with cases. I have 4 cases here. This is audience participation time. So the first is a 68-year-old gentleman who comes in with COPD, develops increasing dyspnea, has a pneumonia on his x-ray. He's transferred to your MICU, intubated, and treated with antibiotics. And over the next few days, his hemoglobin drops to 8.5. Actually, it's a female. She appears to be euvolemic. Blood pressure is stable. So the question is, who's going to give blood at 8.5? Anyone giving blood at 8.5? Who's waiting till 8? Anyone giving at 8? 7? Anyone at 7? We got a handful of hands. Who's waiting till 6? Who can't raise their hand? Okay, there we go. Okay, we got them. All right, the next is an 80-year-old woman, 2 days post-op from a hip fracture repair. Past history is significant for hypertension, diabetes, and patient had a myocardial infarction. Post-op, the patient's having trouble walking, is tired and weak. Exam is clean, hemoglobin's 8.5. So we have an 80-year-old with lots of comorbidity who's giving blood at 8.5. Anyone giving blood at 8.5? Who's waiting till 8? Who's waiting till 7? Who's waiting till 6? Do we have any 6s here? Okay, and then we had a whole bunch of people who wouldn't raise their hand. Okay, let's see those again. Okay, the third case, a 72-year-old diabetic presents to the ER with chest pain, cath lab shows triple vessel disease, valve dysfunction. The patient goes for a cabbage, and post-op goes from a hemoglobin of 12 to 9, and the following day is 8.5. That patient's clinically stable. Are you giving blood at 8.5? Anyone giving blood at 8.5? How about 8? There's someone giving at, how about 7.5? How about that for a question? There we go. 7. Okay, we got a 7. And then 6. Okay. And then the last case, a 66-year-old guy comes in with chest pain to the ER, has an ST segment elevated myocardial infarction on the EKG. He's slipped off to the cath lab. He has an LAD lesion, which stent's inserted. On admission, the hemoglobin's 10.1. Following day, he drops to 8.5. Patient had a melanotic bleed, and the vitals are stable. So who's giving blood in this acute MI patient at 8.5? Anyone giving at 8.5? Who's waiting till 8? Who's waiting till 7? Okay, a handful of 7s. Okay, so I'm going to go through the data now and I'll come back to these cases at the end and tell you what I think the evidence says and what I might suggest in those situations. So you're going to the bedside, you're trying to decide, should I give blood or not? Okay, and so you're going to weigh the risks versus the benefits, of course, like every other medical decision. The risk side of the equation includes the adverse effects of blood transfusion, but also the risks of anemia. So you need to factor that into your decision-making. And if you give blood, you're expecting, maybe there's evidence that you could influence mortality, morbidity, and then so-called functional recovery, the ability to take care of yourself, to do activities of daily living and such. So we're going to look at some of that evidence for each of these boxes here. So let's begin very, very briefly. This is going to be an abbreviated version of this, the side effects of allogeneic transfusion. And you can see across the top here, you can have rates of events from 1 to 10, all the way to 1 in 100 million. And if you look at the common stuff that we always talk about, right? We're worried about HIV. We're worried about Hep C. We're worried about Hep B. We're worried about hemolysis. The good news is these things are so uncommon that they're not clinically important. Okay, they're not clinically, they just should not be entering into your clinical decision-making because they're so uncommon. But fever, of course, is quite common, but easily managed. So there's new options, new issues coming up here, which I call TACO and trolley. So what are they? So trolley stands for transfusion-related acute lung injury. So this is an acute ARDS-like picture. Patient develops bilateral alveolar infiltrates. You're trying to distinguish this from someone who's in heart failure. Typically occurs within 2 hours of the receipt of a blood product. And these people can look infected with chills, fever, dyspnea, cyanotic, blood pressure can be up or down. So they're sick. In the full-blown version, they're quite sick, and once again can occur with any blood product. Now you're trying to distinguish this from what the blood people like to call as TACO. It's heart failure. I don't know why we need our own name here. This is obviously volume overload. How frequent it occurs depends on the patients that you're administering the blood to. The event rates are somewhere in the 1% to 3% typically, and it's certainly common, it's clinically important, and you all know how to manage this, of course. So to summarize, the risks of HIV, hepatitis are exceptionally low, and trolley is an important serious effect, but TACO is much more common. Differentiating TACO from trolley actually can be quite difficult. Clinically, there is no pathognomonic test for trolley. The risk of blood from known problems is very low and comparable to everyday risks. So what are the key take-home messages? When people give these talks, they always talk about, oh, blood is so risky. No, it's not. When considering whether to transfuse a patient, it is not about risk. The risk is low. Rather, it's about efficacy. Does it, in fact, improve clinical outcomes? And of course, it comes with a cost, and then blood is a finite resource. This is the way I think about that particular aspect of things. So what about the risks of anemia? Let's talk about what happens in that setting. So I'm going to tell you about some early work that we did way back in 1996. This is my first NIH grant in which we had a retrospective cohort study of patients who declined blood for religious reasons. So these are patients of the Jehovah's Witness faith. Our primary outcome here was 30-day mortality. We also looked at morbidity. Cardiovascular disease in this study was defined as patients with a history of MI, angina, heart failure, peripheral vascular disease. And this is way back before everyone under the sun had a bloodless medicine program. We had 1,958 patients who went to the operating room who were 18 years of age or older. So what did we find? Here is the preoperative hemoglobin, the numbers of patients in each group with the proportion who died with their confidence intervals. So if you go down to the bottom of the slide, you can see most patients had normal or near normal hemoglobin levels, and with a very low mortality. But as their preoperative hemoglobin falls, there's roughly a linear relationship between their preoperative hemoglobin and the risk of dying. Now, the main finding in this, I think that's most interesting, is here is plotted where we plot the preoperative hemoglobin by the adjusted odds of death. This is all-cause mortality here. Here in blue are patients without cardiovascular disease. Here in red are patients with cardiovascular disease. And what you can see here is both curves begin to take off at that often criticized 10 grams per deciliter, but that the patients with cardiovascular disease, their odds of death rose much more rapidly than patients without cardiovascular disease. And these curves are statistically significant different. That's what the test for interaction shows. Now, we took that same cohort and we said, well, what about their postoperative hemoglobin? What about their postoperative hemoglobin? And there were 300 patients who had hemoglobins less than 8. And we looked at them, and you can see here, down here at the bottom, there are 99 patients between 7 and 8, and none of those patients died. And below, between 5 and 6 grams, about a 9% mortality in that group. But below 5 grams, they don't do well, and the mortality begins to rapidly rise. And this, I think, data is interesting and important in your management of this community, this group of patients. But clearly showing that anemia appears to be associated with all-cause mortality. So to summarize, mortality and morbidity rises as the hemoglobin falls, and human data suggests that patients with cardiovascular disease may be less tolerant of anemia than patients without cardiovascular disease. Now, I have not shown you that giving blood makes a difference to this group, right? Those patients who have those very low hemoglobins and lots of underlying cardiac disease, that may be the reason they're dying. It may not specifically be related to the anemia. They just may have so much comorbidity. So what you need to do is to do those experiments. You need to show that giving more blood or not makes a difference on those patients' outcomes. And so now what I'm going to do is turn to the clinical trial evidence overall, and then I'll focus more on the cardiovascular patient. So here's a slide you can't see. This is a lousy slide, okay? And what I'm going to show you is this is a summary of the trials that were published up to 2021 that we included in our Cochrane systematic review. The way these trials work is patients are randomized to so-called restrictive transfusion, which means less blood, or liberal transfusion, which means more blood. And then these were all the trials that were performed. And then what you can see here, if you blow this up, if you're randomized to the group that gets less blood, you get about 40% less blood. So all this shows is that an experiment was done and that you could create two groups that would be different, although a lot of the trials didn't achieve that. But this overall, you see about a 40% less frequency of blood transfusion. But the question, of course, is how does it influence outcome? That's what you want to know. How does it influence mortality and morbidity? So we go to the classic trial. Many of you were raising your hand at 7 grams. Here's what the trial that started this whole field. This is done by Paul Hébert, who is a critical care doctor, who was the chair of medicine in Montreal, and he's now actually the director of CIHR in Canada. That's the head of the NIH equivalent in Canada. So what did they do? They did a trial of consecutive ICU patients with hemoglobins less than 9. They randomly allocated them to a 7 threshold and maintaining their hemoglobin between 7 and 9, or a liberal threshold where they gave enough blood to get their hemoglobin above 10. And their primary outcome was all-cause mortality at 30 days. They had about 400 patients in the restrictive group, 400 in the liberal group. And you can see the group that got less blood had a mortality of 18.7% versus the group that got more blood had a mortality of 23% or so. These results are not statistically significant, but the key point to emphasize in all these trials, if you can't show that using more blood improves outcome, you might as well use less blood, okay? Costs less, avoids any uncommon side effects, okay? So all the trials are designed to either show that non-inferiority or have to show superiority of using a liberal threshold. Second trial to tell you about is my own, called the FOCUS trial. This was published in New England in 2011, funded by the NIH. This is a trial in hip fracture patients with underlying cardiovascular disease or risk factors. Their hemoglobin had to be less than 10. This trial is a 10 versus 8 or symptoms trial. So I always incorporate symptoms into my lower group. That is, if a patient doesn't meet the hemoglobin threshold, but is having indications and symptoms that deserve transfusion, that is built into my protocol. Our primary outcome actually was function in this trial. We looked at mortality, MI, and morbidity. And this trial had 2,016 patients from 47 centers in the US and Canada. Our primary outcome, as I said, was not walking or dead at 60 days. Okay, so it's function. What do older people care about is independence of walking, taking care of themselves, okay? And so that's why we made this the primary outcome. And the idea is you give more blood, they're going to be able to do that, right? No, that's not what we found, in fact. You can see here, you don't need to be a fancy statistician. 35% in the liberal group, 34% at 60 days, at 30 days, 46 and 48. So no evidence that using more blood improved functional capacity in these patients. Well, what about mortality? So we published a follow-up study in The Lancet in 2015, and we had a mean of 3.1 years follow-up on these patients. These curves are pretty closely overlapping here. The point estimate was 1.09, non-significant confidence intervals. So we did not demonstrate that patients' long-term mortality was related to liberal versus restrictive threshold. So the third trial I want to tell you about, this is a group that does a lot of cardiac surgery here. This is called the TRIX trial. David Mazur was the first author on this, who's an anesthesiologist from Toronto. They did a 5,200 patient trial. They took patients undergoing cardiac surgery who had a Euro score of 6 or greater. That's a measure that means that they're more likely to get transfused. Transfusion protocol was started at the induction of anesthesia. The restrictive group was a 7.5 threshold. The liberal was 9.5 in the operating room or in the post-op ICU. When they get to the floors, they used an 8.5 threshold. In general, almost all the patients who got blood in the liberal were either in the OR or in the ICU. The primary was a composite of death from any cause, MI, stroke, or new onset renal failure by hospital discharge or day 28. So what did they find? Well, in their composite, you can see the restrictive group had 11.4% event rate. The liberal group had a 12.5% event rate. Non-significant differences. They looked at all-cause mortality, also not significantly different. They looked at recurrent MI, not significant. So they did not demonstrate any superiority of liberal transfusion. And in their trial, they used a 7.5 gram threshold. So we have been reviewing this literature for a number of years, summarizing it in a Cochrane review. We're just about ready to update this. We submitted and had a revision that we're in the middle of completing or updating, but the basic results are not going to change from what I'm going to show you today. And so what did we find in this? If you look at the trials back then, there were 16,000 patients of 30 trials looking at 30-day mortality. Relative risk was 1.00. I guess that's unity, would you say? And with very tight confidence intervals between 0.86 and 1.16. So clearly no effect on 30-day mortality. We looked at all these other outcomes. Now they trend one direction or the other, but none of them were significant. So I would summarize that liberal transfusion did not improve outcome or harm patients, and something that's never talked about, restrictive transfusion did not improve outcome or harm patients. So the point here is that we did not show really differences between the two arms, and therefore, of course, you would recommend a restrictive threshold in most patients. All right, so we're here at Cardiology Grand Rounds, okay? So like you want to hear about the cardiology focus here, and that's what I'm going to tell you about now. So we go back to this figure that I showed you earlier, which suggested that patients with cardiovascular disease are less tolerant of anemia than patients without cardiovascular disease. Here's a subgroup analysis. This is from the TRIX trial. So the original ICU trial that established 7 as the threshold. Overall, you can see here that the restrictive group did a bit better than the liberal group, not significantly, but certainly these Kaplan-Meier curves would suggest there's no harm in restrictive. So they did a subgroup analysis published in Critical Care Medicine where they took patients with ischemic heart disease, and look here, the curves flip, with the liberal group doing a bit better than the restrictive group, not significant, small numbers, underpowered. Interesting, maybe it's hypothesis generating. I'll just show you the evidence, okay? So now I'll go to the MINT pilot. This is a pilot study. This is funded by the NHLBI, published in the American Heart Journal in 2013. So in this trial, we randomized patients once again to a 10 or an 8 or symptoms threshold, and we took patients with acute MI with hemoglobins less than 10, and we enrolled those. We had a trial of 110 patients. We lost 1 patient to follow-up. Here in Group A, you can see of the primary outcome in this pilot study of death, MI, unscheduled revascularization, event rate was 10.9% versus 25% in Group B. And what, of course, catches your eye is 1 death in Group A and 7 deaths in Group B. So we're back to audience participation time. Who thinks Group A is restrictive transfusion? Who thinks A is liberal transfusion? Who is not willing to raise their hand? All of you, okay? No guts around here to make a commitment. What's the story here, guys? What's the story here? So, what did we find? Well, it looked like liberal might be better. Now, this is my trial, so I guess you should be suspicious of it, right? But it's actually a small study. Small trials are notoriously unreliable. When you do the big trials, you often don't replicate those results. You should not base your clinical decision-making on this trial. But it sure as hell was helpful in getting my big grant to do the big one. So I will acknowledge that benefit here, and I certainly was not hesitant to talk it up a bit. All right, so there's a second important trial called Reality. Okay, this trial was led by Gabriel Steg, who you probably know, Joe, and Tabasson Simone. Gregory Duquois was the first author, published in JAMA. In this trial, they took MI patients with hemoglobin between 7 and 10. They randomized them to a liberal versus restrictive of 10 versus 8. And in their primary, they had 30-day MACE, defined as in this trial, death, reinfarction, stroke, emergency revascularization. And what you can see here is that the restrictive group did a bit better, 11% for the primary versus 14% in the liberal. And this met the definition of non-inferiority in that particular trial. So I'm now going to come back to this issue and now show you the data from the MIT trial, which was published in New England Journal in December of 2023. This is funded by the NIH as well. We enrolled patients from 2017 to 23. We had 144 sites in the US, Canada, France, Brazil, New Zealand, and Australia. Okay, and you can see here the distribution of cases. Most cases were in North America, where we started the trial in US and Canada. And then as COVID happened and every other crazy things was going on in this world, we expanded the trial to try to make sure we could meet our recruitment targets to Brazil, to France, which was performed by the group that did the Reality trial. They just rolled their sites over into MINT. And then we had a handful of cases in Australia and New Zealand. So we enrolled patients who were 18 years of age or older, who had a STEMI or non-STEMI. Most patients had type 1 or type 2 MI, and their hemoglobins had to be less than 10 within 24 hours. We excluded anyone with uncontrolled bleeding, receiving palliative treatment, scheduled for cardiac surgery during that admission, and of course, anyone who declined a blood transfusion. The protocol called for random allocation to a restrictive strategy where transfusion was permitted but not required when the hemoglobin was less than 8, and strongly recommended when less than 7. Or if they had anginal symptoms not controlled by medications. This was a strategy, and we basically told the clinicians, below 8, it's up to you. You do what you want to do, okay? In the liberal strategy, okay, 1 unit of blood was administered immediately, and then we encouraged them to maintain their hemoglobin above 10 throughout hospital discharge or 30 days. So who was enrolled in this trial? The mean age was 72. Nearly half were females. And the key thing here is that 42% had a type 1, but over half of the patients had type 2 MI. That's unusual in most MI trials. And you can see 14% were intubated, 12% were on dialysis, a very, very sick group of patients. So we randomized those patients to a liberal and a restrictive. Here in blue is the restrictive group, and you can see that the number of units that these patients got was 1,200 with an average of 0.7. And the group that got randomized, the liberal group, got 3.5-fold more blood post-randomization, divided by about a third of 1, 2, and 3 units. So big differences in the amount of blood used. The differences in hemoglobin, mean hemoglobin levels during the first 3 days was about 1.6 grams per deciliter. So our primary outcome was all-cause mortality or recurrent myocardial adjudicated infarction. And what did we find? In the restrictive group, 295 out of 1,749, or 16.9%, had our primary outcome. And in the liberal group, 14.5% had our primary, or 255 of 1,755, yielding a relative risk of 1.16 with a lower confidence interval of 1.00, upper confidence interval of 1.35. But we were missing the primary in 52 patients, and we had to impute those results. And look at this, 1.1 5-point estimate and a lower confidence interval of 0.99. Heartbreaking, I might say, okay? And the p-value was 0.07, okay? 0.07. So what about our secondary outcomes? Well, you know, we looked at the components of our primary, death, and the relative risk was 1.19, MI 1.19, death MI unscheduled revascularization, 1.13. All these favored liberal, but the confidence intervals overlap 1. We were very worried about heart failure in this group, right? Because we're giving volume to a group of patients with LV dysfunction. A lot of acute MI, a lot of these patients have LV dysfunction. And it turned out, yet guess what? You guys know how to manage heart failure. You give diuretics, you know how to manage those. And while there was a bit more, a 0.5% greater frequency in the liberal versus restrictive, you know, it was managed very, very well. And then cardiac death was highly significant. Yielding a relative risk of 1.74, favoring liberal. So you'll notice all these boxes are pretty much favoring liberal. So to summarize, the MINT trial did not demonstrate a statistically significant difference in the rate of 30-day death or recurrent MI in patients with acute MI and anemia assigned to a restrictive compared to a liberal strategy. While not significant, the point estimates for the primary and secondary outcomes consistently favored a liberal strategy, and that heart failure and other safety outcomes were comparable in the two transfusion groups. So what are the clinical implications from our point of view? In contrast to other clinical settings, the trial results suggest that a liberal transfusion strategy has the potential for clinical benefit with an acceptable risk of harm. And our clinical take-home is that a liberal transfusion strategy may be the most prudent approach to transfusion in anemic patients with acute myocardial infarction. So there were 2 letters to the editor, okay? And when you get letters to the editor, you're saying, oh, okay, what are the complaints going to be, right? What's the complaints? Well, we got 2 letters to the editor that I wanted to give I wanted to thank them. So the first calculated what they called a reverse fragility index, which represents the number of patients that would change non-significant to significant results. So if you move just 2 additional patients to favor the liberal transfusion strategy, you got your significant p-value. That out of 3,500, I would say we were close. Would you agree with that one? Okay. Now, the second thing they did was a Bayesian analysis, which is something I find very attractive here. And so, you know, a Bayesian analysis, you start with a prior probability. You say, I think that transfusion is going to improve patients with acute myocardial infarction who are anemic, and I think that's possible. And if you think that's possible, you had a 99% likelihood that you're helping that patient. But let's take the skeptical perspective, which there's a lot of skeptics, appropriately, a lot of skeptics here. And even if you start with a low prior, a skeptical prior, you still had over a 90% probability that transfusion was benefiting those patients with a liberal approach. Or another way to look at it is that by sticking with a restrictive approach, you're potentially harming those patients. And then I would ask you all, how many treatments that you think you have a 90% chance of helping a patient would you give? I would argue almost everyone in that situation. That's the Bayesian analysis, letter to the editor, New England Journal of Medicine. All right, now, I want to just show you 2 subgroups, okay? 2 subgroups, because this group, I think, would be interested. The first is type 1 versus type 2. These results were actually a bit unexpected in heart failure. So this paper was published in Circulation, a subgroup by Andrew D. Philippus. And here, what you can see here is in type 1, for the composite of MI and death, you can see here these curves separate very nicely, right? And then for type 2, the curves are kind of superimposed. Now, the way you decide if there's a differential effect statistically is you do a test for interaction. That test for interaction was not significant. This should be 0.16. That's a typo. Sorry about that. It should be 0.16, okay? And so we didn't show definitively that was proof, but, you know, kind of looks that way, doesn't it? Looks that way to me. Heart failure is another really important group. This paper got published in Circulation Heart Failure yesterday, so you know, certainly current here. And the issue here is if you take patients without heart failure, you're seeing that the groups were pretty comparable, okay? And patients with baseline heart failure, you still saw a beneficial effect of liberal transfusion. So clinically, you have a patient with heart failure, the instincts would be, oh, I don't want to give volume there, okay? I don't want to give volume there. Yeah, I might harm that patient. The subgroup analysis in MINT would say you're not harming patients. We didn't show a differential effect. based on our interaction, which is also done wrong. It's 0.18. But nevertheless, I think these findings are important that MINT still applies to patients with baseline heart failure. Now, you need to manage them differently. You need to give the blood slowly. You need to make sure you diurese them. You make sure they're euvolemic, and then give them the extra blood. All right. So that's the trial data at this point. Now, we have gone on to do an individual patient data meta-analysis. So the way you do that is you have to get the trials. There have been 4 trials in acute MI. We did 2 of them. That was easy to get those, right? The reality trial was done by the French, who were also collaborators of ours on MINT, so they were free with their trial. And then we had one other small trial that Sunil did, and he's on our steering committee. So we had all the groups that were a part of this trial, and they sent us the trial data. Okay, and so we published this result in New England Journal Evidence the end of last year. And what you can see here is that the point estimate of 1.13 is about the same as it was in MINT alone. Confidence interval is 0.97 compared to 0.99. So the results are pretty much showing the same thing at 30 days, but still not statistically significant except for cardiac death. So basically the same results as MINT. But the new findings from our meta-analysis is because we had time to death, we could do a formal survival analysis here. And what you can see here is that these curves separate around 5 days. They remain parallel. They did not quite meet statistical significance, as I've already shown you, in all-cause mortality. But at 6 months, the hazard ratio was 1.08, and the confidence intervals were significant. So we have statistical evidence that a liberal transfusion strategy appeared to be superior to a restrictive strategy out to 6 months or so. Now, next question, okay? So that's the next question, another analysis that we've just published in the Annals of Internal Medicine. If you were to do these trials, if you were to design these trials, what you would like to do is a trial where you use a 7 threshold, where you use an 8 threshold, where you use a 9 threshold and a 10 threshold, and compare them, because where's the, we've been said, well, you chose arbitrary numbers. Well, not really, but we chose reasonable numbers. But if you could, you would look at each of those thresholds, right? And then you would try to decide, see if one threshold is better or not than others. So you can do this. We did this in what's called a target trial emulation. If you're interested in this, this is in the Annals of Internal Medicine. And essentially, if we go down to this big red box and we look at the cumulative incidence of death, and we'll just go to the 30-day data here, you can see at 7-gram threshold, it was 14% mortality, 8 grams, 11% mortality, and then 9 and 10 were pretty much the same. Now, these confidence intervals are very wide. So you have to consider that, and this still in the end is observational, it's not trial. But this data suggests, I think, that relative to a 10 threshold, that results suggest that the lower the restrictive threshold, the greater increased incidence of death, or MI, in patients with acute MI. Now, the imprecision of these estimates, however, prevent explicit recommendations. But when you look at that data, if you're of the mindset, gee, I don't really want to go to 10, but it looks like if I go to 9, I'm getting most of what I'm hoping for. Here's some evidence to support that. The trials didn't test this, okay? The trials tested 10, but if you're willing to sort of consider this emulation, target trial emulation, you have some evidence to justify a 9 threshold if that's what you're more comfortable with. Now, let's go to guidelines. So we're now at guidelines time. How am I doing? I'm doing okay with time, yep. Okay, so we published the red cell transfusion guidelines in 2023 in JAMA. I was chair of this committee. Now, this was done before MINT came out. So these guidelines do not include a recommendation on MI. This is in every other setting here. And these guidelines basically said in hospitalized adult patients who are hemodynamically stable, the international panel recommends a restrictive strategy considering transfusion when the hemoglobin is less than 7. Now, we debated, though, is some of the trials, half the trials, used 8. So should you use 7 for everyone, or should you perhaps modify your threshold based on the trial data? You can see the cardiac surgery trial used 7.5. Most of the orthopedic trials and cardiovascular-oriented trials used 8. And so my view is you follow the data, You don't make it up. And so my preference would be to use the thresholds that were used in the trials. I will tell you that the committee had 22 people, and the vote was 11 to 11, actually, 11 to 11. So there was clearly different points of view here, and so you can pick the one that you prefer, and the guidelines are consistent with it, okay? So a key element of these guidelines, and this might be the most important slide of the whole time, the whole talk, and that is what we call a good practice statement. And we consider it good clinical practice in deciding when to transfuse a particular patient to consider not only the number, not only the hemoglobin level, but symptoms, signs, other laboratory results, the overall clinical context of that patient. Be doctors, be clinicians, okay? Now, this makes clinical common sense to me. It doesn't make any sense that one number would be right for every patient, but recognize I don't have data to support. I've been emphasizing data. I've been emphasizing trials. Okay, I don't have data for this, but you know, there's a lot of things we don't have data for, and this makes clinical common sense. Okay. Now, lastly, one more set of guidelines just came out in about 3 weeks ago, published by the ACC, AHA, and lots of other groups, guidelines and management of patients with acute coronary syndrome. What did they say? They looked at top take-home messages. Number 8 of 9 top take-home messages was red blood cell transfusion to maintain a hemoglobin of 10 grams may be reasonable in patients with ACS and acute or chronic anemia who are not actively bleeding. So we now have the cardiology guidelines suggesting that maybe a more liberal approach is appropriate. I'm done, except for the cases. So I'm going to go back to those cases. And the first patient is a 68-year-old person in the ICU. This is similar to the TRIC trial. The hemoglobin was 8.5. That trial suggested that a 7 threshold was the right number, and I would generally, in most patients, be thinking about using a restrictive threshold in my critical care setting, general critical care setting of 7 threshold. In this hip fracture patient, okay, this is similar to the patient who was enrolled in the FOCUS trial, which compared 8 versus 10. I would use an 8 threshold in general in this group of patients, recognizing that maybe you could go to 7. It's not been tested, though. It's not been tested. So it would be reasonable to follow the trial evidence and consider transfusing around 8. We have this cardiac surgery patient here whose post-op goes to 8.5. The biggest trial in the field, the TRICS trial, TRICS-3 trial, used a 7.5 threshold. Why 7.5 instead of 7 or 8? I don't know. That's the number they chose. That's the number they chose. So if you want to follow the evidence, then 7.5 would be your number in this particular setting. And then finally, your acute MI patient who goes down to 8.5. If you want to follow the current evidence and the current ACC guidelines, then you would be transfusing this patient up and near around 10 or so. Now, I will tell you that if you buy the target trial emulation, another approach to consider is getting people around 9, getting them around 9 and then reassessing them. How are they doing? What do their vital signs look like? Are they having any recurrent discomfort? Have they been completely revascularized? What's their physiology? Maybe then, if they're doing well and they don't have high risk parameters, then maybe you stick at 9. If they don't look good, they're having any kind of symptoms, then get them to 10. That would be the way that I think I'm beginning to practice. But you know, there's a lot of judgment in what I've just described for you. So overall conclusions: clinical trial data support the safety of a restrictive transfusion strategy of 7 to 8 in most patients. In patients with acute MI, trial data suggested the potential benefit of a liberal transfusion strategy of 10 grams per deciliter. I'll be happy to entertain questions. Thank you so much.